observed is within the last couple of years, these train coaches or train ambulances did come up, operating from Delhi, maybe from other centers also in the private network, not in government setup, but in the private network, they are there. They are operating in India. It's a news for me as well, but I have been seeing it for the past couple of years. They are there as well. So, in fact, what is needed is a vision for the entire country. Somebody needs to sit down and plan it accordingly. There I see the future, because of a successful program as well as many patients to benefit from technologies like this. Certainly a vision and planning is necessary. Thank you.
So could you go back to the slide of the mobile ECMO? I wanted to ask you a question. The equipment.
That trolley.
No, just before this. You had a list of the ECMO. No.
That trolley was interesting. No?
It's a usual sort of trolley which we have got. It just needs to be improvised really.
Nice.
In fact, while even shifting from patient from OT to ICU, I would love to have something like that.
Sorry, what is your specific question?
The question is the equipment which you have detailed.
Right.
Yes, this Levitronics. No, the previous one. Slide previous to this one. Yeah, can the same equipment, is it available in India, and can the same be...
I went to Ann Arbor a couple of months ago for the 25th anniversary of ELSO. They did say we have presence of Levitronics Centrimag in India.
So I think they are either in Hyderabad or Bangalore, I believe.
Yeah.
Electronics.
Or could be even in Chennai also.
And
But
can the same equipment then be used with the patient
That's
when
right.
he goes to the hospital setup,
That's
instead of changing over to the hospital ECMO?
Yeah.
This
So
is actually,
I'm not an advocate for any company as such, but even the Mackie mission can be used for that. So
this is I
using
agree
a
with you.
smaller mission. That's it.
And what we have at Meadows, you can transport a patient with battery. Only battery. You don't need anything else.
No, but the
But
efficiency of the
time
machine.
depends on
But
the
the
duration.
battery runs for 2 hours. Okay.
Yeah.
So if you are confident about for 2 hours, you can see that patient only on battery. You need only battery and that
But
central
is
pump.
the
That's it.
machine as efficient as a hospital-based machine? Is what my question.
It is. It's no different to.
I mean,
the
there are certain
hospital-based
machines which
mission.
can be used only for a particular number of hours.
The reason why we have gone for Centrimag is probably it's a compactness. It's like a battery size, smaller than the projector you are seeing in front of you. It is of that size. So that is the reason it goes and compactly it sits on the trolley. So that's the reason we have gone for that. If we don't have, it is available, but if we don't have the same one, maybe we can go for any other one which we will be using on the unit as well as on the transport also.
But you need expertise. For that you will done some hundreds of cases. Then only you can be.
We have to start at some stage.
Yeah. But you can do it with. So you need once the.
No, in an organization like mine, if I bid for a mobile ECMO, it can be used in a ICU scenario also. That would be more cost effective for us. To
Absolutely.
establish the center, do 100, 200 cases, and then have an ECMO center per se.
That's right.
We have
Yes,
to
we
start,
can.
but I think we can start with the mobile thing first
Yeah.
and then shift over to the hospital.
My vision at the moment is if something like this can be developed with us, let us fly taking that mission with us
Yes.
to a destination area on the routine flight, and then put the patient on ECMO and then bring them back by road also, it doesn't matter. Or bring them back by train ambulance if it is available, doesn't matter. Because you will be able, it will be cost effective, that's what I'm saying.
That's what like Meadows. What they have, you can you don't need to carry a heater cooler. It is a separate unit, small, and that main this one unit is a separate. Console is separate, and in console the battery also is separate. So either you can take whole machine. I'm talking about transport. if your ambulance is well equipped, either you can take only the console and just leave the heater cooler at your place, you don't need heater cooler, or you just take battery only. They have all three options. That machine is only you can carry in your hand. It's around 8 or 9 kg. So you can walk with that, along with the patient.
I think the answer lies in
That's a
multiple
very good
portals.
entry. You can just look at that.
On the also central web page, you also see the purpose-built equipment there. But I think for us to be cost-effective, it is better if we innovate and develop it locally in our own hospitals.
Because I have seen one YouTube
Cost-effective.
video of a German video where one girl, I don't know if you've seen it also, 10 or 12-year-old girl drowning. A helicopter came, put her on ECMO,
Yeah.
and
See, that
Save
is
her
what
life.
where I was in Regensburg. Alan, he is a perfusionist, but he is in ECMO since last so many years. He has initiated ECMO at home also. You get a call, patient being arrested at home, and the team would be reached. Helicopter is always ready. घर पे जाके ECMO initiate करके then just bring back the patient to the hospital. They have done all sorts of ECMOs now. At home, in battle, this among this main area trauma. Then he helped the American government, as an intermediate. If they have some ECMO required patients, then to just provide all services from Germany, because from this Asian thing, it's too far actually. So he is officially been appointed by this American government for ECMO services. They give him all liberty, whichever kind of plane, and he is expert. He has done a lot of ECMO at various places.
because both the aircraft which you have shown now, the Indian Air
That's
Force has got both the
that's a cargo carrier.
C-17
It's
as
a cargo.
well as the Globemaster. Both are now available in India.
Yeah,
We
it's
have
a
bought
cargo.
these planes.
Nice.
Okay.
Whole ambulance can go in.
Yes. And we have a casualty mode also in the armed forces. So we can use that also.
And my friends are not to be seen around. Let me continue with the second talk. It's pruning an ECMO. I like this. What is the implication? Why? What do you think so? This is how nature has intended for us. If you look at any animal in the world except human being, they all will be in prone position while they are resting. All of them, with the exception of man. So everybody will be in prone position. So that's what nature wants us to do. Why it is important? Because we are dealing fundamentally with the principles and management of ARDS. For improving the ventilation, mostly the perfusion of the dependent parts of the lung, pruning is extremely important. It is an important adjunct in the management of respiratory failure, physiotherapy and prone positioning. Even what I want to cover here, not only pruning the patient completely, which will be ideal, but if your cannula doesn't allow that, maybe you can put the patient with the right side up, left side up, partly, try to mobilize, because this has a lot to do. ECMO gives you an opportunity to get the lungs back to normal, near normal, as soon as possible. So the moment you put on ECMO, your clock starts ticking, and you have to bring the patient back to normal as soon as possible. Some patients with severe respiratory failure receiving ECMO may benefit from prone positioning. So, and it is safe to prone patient on ECMO with certain precautions. The aims are to improve the oxygenation and respiratory mechanics, to homogenize pleural pressure gradient, alveolar inflation and ventilation distribution, to increase the lung volume and reduce the amount of atelectatic regions, to facilitate drainage of secretions and reduce ventilator lung injury. That's what we tend to do. So I have seen that in many places, pruning is dealt with anxieties and worries that what might happen to the cannulae, and patients are heavy, especially the adults. Let us not do that. It will be in children, it will be easier compared to adults. But what I have seen is, with experience, it becomes easier. Even to pruning the adults is also not that difficult. Studies from Gattinoni and all have seen how densely the posterior parts of the lungs are consolidated and how much lung volume you acquire once you reverse the technology with that. by putting the patients in prone position. The choice is it has to be weighed against the potential risk of turning and putting the patient in a prone position against losing the cannulae or causing pressure source, etc. Ideally, if there is a policy and procedure, practice and experience of the carers in applying this technology, repositioning of the head, 2-hourly repositioning of the arms and correct protocol really, that will be very, very helpful in adapting to this technology. The disadvantages and the precautions we need to worry about are dislodgement or malfunction of the tubes and cannulae. Tubes probably is less of a problem than the cannulae, so there should be meticulous attention towards positioning of the cannulae and migration of the cannulae when we are doing this. The impact of cannula related complications could be potentially disastrous, so one has to be extremely careful with that. The complications of proning could be with the facial edema, dislodgement of the endotracheal tube and ECMO cannulae, pressure source, transitory decrease in saturations, arrhythmias, and need for deep sedation, at least during this procedure when we're turning them around. Proning in children is relatively easy, just to flip them over, taking care of the lines and avoiding pressure effects over the pressure points. Proning the adults, that is much more difficult as it is dealt with. It needs more of human power, more people to be around. But at Greenfield and in some other places in the world also, they have developed the ways how do they flip over the patient from side to side. As you are seeing here, the patient is covered with a blanket or a wrap over here, and people are holding on to him. But definitely somebody will be taking care of the cannula. A fellow will be taking care of the cannulae and the tubes at the head end, mainly the cannulae at that time. Get rid of the lines which are not necessary during this procedure, then turn them over to the midline. Are there any other pictures here? See, I can show you. See, putting a pillows over the body will help in preventing the pressure source on the fixed areas. This is Chris Harvey, my colleague. You will be seeing him this afternoon. So, patient is with this patient is smiling as well. You might have noticed that he is not a real patient. He is one of helpers and the nurses on the unit. Then she is flipped over after she is taken into the midline position like this to the other side, and Chris there taking care of the cannulae at the head end. And patient is flipped over to the opposite side on those pillows. So this is how they look like with the neck cannulae and pillows underneath, helping in stabilizing the stabilizing and helping with the pressure source. So that is a simple mechanism, but it needs lots of practice. It definitely needs lots and lots of practice with that. Due to interest of the time, I am not going into further details about this, but if you are interested, please get back to me. I just deal with the indications and contraindications. 17 hours of ECMO with no improvement in the gas exchange and no improvement in the chest radiograph with evidence of collapse and infiltrates. This is more or less an absolute indication for proning your patient. You can shift them sideways as well if you don't want to prone them, if they are big people and you have worries about that. But practice makes it perfect. The contraindications are raised ICT, known suspected spinal injury, pathological abdominal distension, pregnancy in second and third trimesters, recent abdominal injury, and within 24 hours of formation of tracheostomy. So I would like to stop over there.
Can you just see those 2 slides of checklist? I think that was going to help us.
Sure. This one?
Yeah.
There must be a remove checklist as
That's
well.
one.
Personnel, family aware, blood gases, cannula, adequate tubal length, if not single cannulation site, non-essential infusions disconnected, all remaining infusions from the head and foot of the bed, eye and mouth care performed, endotracheal tube secured, chest drain secured, bed on max inflate, pillows in place. That is pre. And post, cannula secure, flow stable, make sure that's happening. Monitoring recommended, hemodynamically stable. All infusions are recommended, check position of the pillows, reverse trend line body position, recommence feed and perform gas. As you have seen, many hands are required during this, so my recommendation is do this during the daytime when people are around, and no heroic measures after 5 p.m. or 6 p.m. when the availability of personnel is a bit minimal. But it certainly helps in getting the posterior parts of the lung. Whatever little helps in making the patient's recovery sooner or quicker, that would be ideal really. At the same time, be very, very watchful about position of the cannulae. It would be disastrous, so be very careful about securing and keeping them in the right position. This looks like a simple adaptive mechanism. How can we do that? Any questions?
Can the same be applied for post-cardiac surgery? Roaming as a
After surgery allows.
in atelectatic, because both the lung bases are atelectatic usually in lung surgery.
I don't
What are
do
your
that
recommendations?
immediately, but if the